and welcome to Health Show with Amara from our London studios. Our today's topic is NHS waiting times. It's a hot topic with far-reaching consequences not only for the public but also for the care providers. And it's not a new issue. In each government we come across problems and it almost becomes a political issue, and we see that politicians, they blame each other for that. To discuss that, we have invited in our studios today Mr. Amir Khan, who is a consultant surgeon and also president of APNE, Association of Pakistani Physicians of Northern Europe. Hello, Mr. Amir Khan.
Thank you, Amara. Thanks very much for having me on this show. I think you've touched a very important point there. I don't want to just say it's political and minimize the impact of it. It's a huge issue, so we will discuss as we go. But I think this waiting time and NHS has become a political football. Repeatedly, the government who's in the opposition always blame the one which is in power. And if you've seen, that's been happening every time as we reach the elections. We've always said it's better off that NHS is left to the professionals. There should be a cross-party consensus, and there should be a cross-party panel to look at it, rather than an individual government looking at it. Because it's very easy to manipulate the numbers, and I think I don't want to get into that debate with that one.
So what is the current situation then? What is happening, the current statistics? Because we know that waiting times, they have escalated significantly in recent times. So what is the current statistics, if you could tell our viewers?
Yeah, it's very interesting that people talk about the impact and the numbers at present. We all know that in the past few years, it's actually doubled and tripled, right? And if I give you exact statistics of that one, at present, we got about 3.25 million patients who have been waiting over 18 weeks. If you remember, there was an NHS charter, which was a constitution for NHS for Patients Charter. And that charter said that every patient should be seen, provided treatment within 18 weeks from the time of referral. At present, there are 3.25 million people waiting in this country, out of which 321,000 patients have been waiting over a year now. This number has slightly come down from a year ago, right?
And that would include patients who have been diagnosed with cancer?
No. I think let's keep the cancer targets out of it for a minute. I think I'm talking about mainly general treatment. When we talk about NHS waiting time, it is not just for surgery. It is for all sorts of treatments. And this is from the time of referral to treatment. I know the numbers in the recent years have gone so high that people have forgotten about the charter now, and we are moving away from it. You remember we had a 4 hours waiting time target in A&E. That's been blown off completely, and that's out now. So I think we are at present in a very difficult position, and the numbers are so high that for anyone to manage it or handle it is not going to be easy. That's where I always say that we need a professional approach to it. We need professionals, both medics and the good managers, who could sit together and devise a policy how to take this forward.
So what is the government's policy? What is the initiative to improve the current situation, which is really dire?
At present, because, COVID has been blamed for some of the things, and COVID impact has had some impact because all elective surgeries were cancelled during COVID. Only emergency treatments were being provided at that time. So there is a lot of money going into waiting lists. And that reminds me, if I just take it back, because politically we've been on this type of juncture several times before. I remember when Tony Blair was in power, I think the maximum money which went into NHS was during that period of time. They threw a lot of money, but that money went into bringing the waiting list down rather than putting an infrastructure and resources to address these issues for one and all. Unfortunately, what happens is that when you have a government which is for a limited period of time, they want results in those 5 years, and they want to see some benefit before they go to the next elections. So they do not invest in the infrastructures. What they do is the investment is made to bring the waiting list down. At present, all hospitals are working on Saturdays and Sundays doing elective work. And there are waiting list initiatives. I'm sure my other colleagues will talk more about it. And that's how they are trying to bring the numbers down. But the numbers are huge at present.
You mentioned about Tony Blair. I remember I was a trainee doctor in 2005. And I could see there was a lot of frustration amongst our consultants about employment of a lot of managers. And there was a concept that Tony Blair, all the money they had put in NHS was used to employ more managerial, to have more managerial posts. Do you think that that situation is still the same?
We've had huge increase in managers and less increase as far as the clinical workforce is concerned, right? And the reason that was done was because every government thinks that the managers are the one who will manipulate or who will put pressure on the system to help them to achieve the targets they want to. Whereas clinicians, the top priority is a patient, okay? If you ask me honestly, I think this idea of just, even when the NHS charter came up about 18 weeks of treatment, I think it's a very narrow-minded way of looking at things. We need to look at a broader picture. For me, a patient who needs emergency treatment or cancer treatment is urgent. They will get the treatment. But someone who can wait for something which is elective, that's a different. So I think instead of us just playing with the numbers, we need to be honest to our population, tell them what resources do we have and what can be done in that one.
Right. And talking about managers, one of the frustrations I remember is that managers, they make plans which they think will be a good plans to improve the services, but on the other hand, the clinicians think that what do managers know of, because it should be the clinicians deciding on what kind of care is to be offered to the patients. Mr. Khan, you've worked as in a lead role in your trust. Of course, you were one of the top management, you were in top management roles. Do you think that clinicians, they can do better management roles compared to those who have no clue of how the clinical work is done?
It's a very, very interesting question, and I think some of my colleagues might not agree with me on that one, because I believe we need to work together, right? If you look around, good managers, they have been trained because they can plan things in a way which can help the clinicians to do their job. But that's why the plan will fail if they do not have a clinical buy-in or clinical involvement in making those plans. So I think we need to work together.
Absolutely.
Right?
And
there are certain roles I can do, certain roles you can do. Like you are a gynecologist, I can't do gynae work, right? Similarly, the work which I do, you can't, but we need to work together and try to support each other. So if you make a plan, the professionals should be involved. And when I say professionals, it's not just the doctors, but also professional managers who do it. And I think we need to work together.
I totally agree with you, but with regards to the targets that are set by the management, sometimes people on the shop floor, they think that they are unrealistic and they are just putting too much pressure on the workforce, which is really frustrating because as doctors, our ambition is to provide the best care to the patients, but when there are so many things you have to do in a very short period of time, do you think that brings frustration in the workforce?
It does, and that you're right there. But that is why I'll take you back to our earlier discussion. I think they got to work together to develop those targets. I think they should not be unrealistic. And if we develop them together with doctors and managers together, there will be the targets which will be realistic and achievable. Because to you and me, the priority is the patient, right? And that's why I'll just try to just take you to another part. The thing which happened a few years ago was a consultant contract. When you make a time-sensitive contract, people will look at the clock. You don't need to. None of us, I can guarantee you there's no clinician who will walk away when a patient needs them. If there's some urgency, they will be there, depending on how urgent it is. So stop looking at that. And I think we shouldn't be managing senior clinical staff. We should be working with them and trying to get the best out of it.
Absolutely, because when all the doctors and other healthcare providers, everyone takes up a job in order to provide what they can do the best. But when they're micromanaged, that is, then it just almost creates that feeling of revenge, that if this is how they're doing, we are going to leave at the time that we are supposed to. And that actually has got an impact on the patient care as well. So do you think that patients suffer when that kind of a rift happens between managers and the clinicians?
I think it's a natural phenomenon because people will do that. But my feeling is that we need to make sure that the atmosphere around us should be such that people are able to work to the best of their ability and perform the best. And people will only do their best if they know they're making a difference. But if you start micromanaging, I don't think it works. And I think that is something our management has to understand.
Yeah. And Mr. Khan, you have worked in NHS for several years. Do you think that you have seen a change in how the trusts work when the government changes?
I think the biggest change I've noticed, I've been associated with NHS for almost now 40 years now, and the biggest change I've noticed, it's the lowest morale. I think the staff morale is the lowest at present. People are actually, we never thought it was a job, it was our profession. We came into it because we wanted to serve our population and our ailing people who require our help. But in the last few years, the way clinicians have been treated, morale is very low.
Do you think COVID pandemic had a part to play in that?
Yeah, I think Amara, you hit the nail on the head there, because we did have a issue of waiting times beforehand, but during COVID, because all elective activity was stopped, so what's happened is that the number, it's doubled, basically. The waiting list has doubled since then, and COVID has had some impact. But if you ask me genuinely, I think we need to get out of it now, and we should stop using COVID as an excuse all the time.
Absolutely, because this is what people also say, that they think that NHS staff, they use COVID as an excuse when the care is suboptimal. So to discuss the impact of COVID, let's take online Dr. Nadeem Sajjad Raja. Thank you very much, Dr. Raja, for joining us. We want your views on how the COVID affected the NHS and what pressures are you facing currently and when the pandemic was at the full peak.
Thank you very much for having me on this program. During the COVID, we have seen a sudden surge of COVID infections. So our hospital beds were, I would say that more than 2/3 were occupied by the COVID patients, because that was something very new. A new variant of COVID-19 was circulating in the community and infecting a lot of patients with underlying illnesses. So that's why, and we did not know about the treatment, how to treat the patients. So that's why a lot of beds were occupied. So to make the beds empty, so the other patients who were stable, so they were discharged, and our work was increased, I would say, like 3 times, because of a huge surge of infections. And many of our colleagues, so they were contacting us about the management plan. So of course, our labs were very busy at that time. We were receiving a lot of samples, and our lab staff, they were working day and night, and we were standby. We were always available. And due to this, of course, as Mr. Khan mentioned, a lot of operations, elective operations were cancelled. And it also had a very important impact, not only our services, but also on the mental and physical health of NHS staff. During that time, it was very interesting because we did not see what we normally see. For example, CME infections were very low, new diagnosis of HIV almost negligible. Influenza virus were suppressed because of the use of face masks. But no doubt, our work was increased.
So, Dr. Sajjad, you mentioned the challenges you had during the peak of COVID pandemic. Do you still have those challenges and pressures on your work, or is it getting better? Because we saw that in winters, when the winter started, there was also another surge of COVID, but it was apparently a different variant. So, where do you see yourself currently?
Because of the several mutations now, coronavirus is not as virulent as it was in 2020. And it is very transmissible as compared to that time. That's why we see a lot of COVID cases. So usually coronavirus causes mild to moderate illness, because one thing, mutations not as virulent. The other thing, vaccine uptake. That is very good. That is another reason. And repeated infections, now many of our community members, ordinary people, they have some sort of immunity. That's why we rarely see a severe infection. So it's not really challenging for the microbiologists or healthcare physicians. We are almost now back to normal. So normal working as a microbiologist. We rarely see any admission in ITU due to a coronavirus infection.
That is indeed great news. But you mentioned earlier on that a lot of workforce also suffered from this infection, COVID infection. And did that result in staff shortages in your field as well?
Certainly, that was a big challenge for the hospital administration because of the illness. I'd like to mention about microbiology. So we are always facing a staff shortage. And as I mentioned, we all were available during that time. So our workload was almost double, tripled. And staff shortage, yes, that is always a big challenge for the hospital administration.
Amara, can I ask a question from Dr. Raja?
Sure.
Dr. Raja, while you're there, can I take a liberty and ask you a question? You mentioned that during COVID-19, when there was a surge in 2020, the normal influenza cases and the flu virus were less. And that was mainly to do with people wearing masks and covering face coverings. Do you think if that was the case, because we know every winter we get a problem when the staff is off sick because of normal flu virus, should we ask everyone to wear a mask? Is that an answer?
It is really debatable to wear mask or not to wear mask, because that is debate going on. My personal views are, yes, we did not see, even in my center, I did not see even a single case of influenza A or B or C. And also other common causes of flu-like illness. Mask played a very important role, and we should not forget.
But could it not be that the people were not actually meeting each other, and that may have resulted in decrease in the other infections? Could that not be the reason, and not just the wearing the mask was a factor?
That's I was coming to that point. Thank you very much for mentioning that one. So the second important thing was washing hands. We were either decontaminating our hands or we were washing our hands frequently. And also socialization was very less that time. Not only influenza cases, we did not see other common infections as well, like a CMV, as I mentioned, EBV. And during that time, we also see very less bacteremia cases, very less urinary tract infections. I am in favor of wearing masks, specifically if someone is suffering with flu-like illness, so they should take respiratory precautions.
Yeah, definitely. And We were talking about staff shortage as a result of health workers suffering from the same illness, but there are some staff members who have got long COVID. What do you say about that? I mean, is it something very common, or it's a very rare thing? Because, of course, this has led to morbidity amongst healthcare workers as well as in general population. So what is what is going to be the consequences of having the long COVID, and are these people going to recover?
Due to COVID infections, many people, they suffered with long COVID, renal failure, so many other complications of COVID-19 infection. So there are special clinics, and they are looking after all those patients, and no doubt recovery rate is very good. Nowadays, we don't see the complications as we have seen during the peak of the COVID-19 infection.
I mean, this is one of the consequences of the pandemic, but is this the only major reason, or do you think the staff shortage is due to other issues? For example, we see the junior doctors strike. There are a lot of strikes that have happened. Theatre lists were cancelled, and patients, they were frustrated because they had to wait. They had been waiting for a long time, and when their date was given, junior doctor strike came in.
Yeah, I think lots of factors have come in. I think you mentioned about one was the COVID itself, then the long COVID. Then also we've had a problem is that staff, it's my personal view now, don't take it as gospel or anything like that, that the people, this working from home thing, which has also had a huge impact. People have got used to different type of life now. And I think that has changed. People's perceptions have changed. We've got a huge shortage of staff, and that is not just because of COVID or because of work here. It's mainly because of financial reasons as well. A lot of people have moved on to places like Middle East. A lot of people have moved on to places like Australia and New Zealand and Canada because, one, their working hours are better, and secondly, their pay is better.
Are you talking about junior doctors?
Junior doctors and nurses. Junior doctors and allied healthcare workers, they are moving around as well. So we've lost the workforce.
But isn't it a huge loss for the government? Because, of course, all these junior doctors, their education is supported. I mean, there is some funding from the government. And after they qualify, they actually choose to move to a different country. So is government acknowledging that?
Yeah, but it's very interesting because if you go back, UK health workers at present also, almost I think, if I'm not wrong, it's about more than 50% of them are for those who were trained abroad and they used to come here. But what's happened is now we are suffering with our own medicine. A lot of those people from here who are trained, they are going for a better quality of life to Middle East and to Australia, New Zealand, Canada. Government has to take an initiative there. And I think we have to change the working environment. We have to remunerate the junior doctors and senior doctors better so that they do not go to pastures abroad and they work locally. So we've lost a lot of our workforce because of that. And that is impacting upon the waiting list hugely as well. Because at present, we can't run if you'll see, our theatres, our other places, there is a staff shortage everywhere in NHS. And that got to be addressed. And I think that is a huge impact on it. And you talked about junior doctor strike. It'd be worthwhile you to have a chat with the junior doctors themselves and see how they feel about it.
Yeah, I will definitely get a junior doctor online. But before I do that, is it ethical? Do you justify junior doctors striking?
I think striking for your rights is ethical, and that's a human right. Every individual, we should not label junior doctors as being unethical if they do it. They are using their right,
but that's not
protest.
This is not the ethos of being in a medical profession. Where is the compassion gone?
No, you got to look into it. What are the factors why that's happening? A junior doctor who works pretty hard, if you look around, people who go into medicine are usually the cream, right? They get best grades in their A levels and O levels to get to that stage. Admission isn't easy. Once they get there, they work pretty hard for 5-6 years, while their counterpart in other professions have already moved on with their life, whereas these people are still studying. Then again, when they come into the hospital practice, it's another 10 years average training before they start becoming to the senior post. It's a lot of investment. We need to value that. We need to understand that those people have come into this profession not just for money, they also want to help, but they have got to live.
Let's take a junior doctor online. It's Dr. Amara Sohail. Dr. Sohail, would you like to tell us your stance on the junior doctor strike? Do you consider it ethical? Because public takes it as an unethical and immoral act of junior doctors.
I mean, thank you very much for having me on the show. Just a little bit of background. I'm currently a surgical trainee. I'm training in trauma and orthopedics in the Kent, Surrey, Sussex area. And I've done my F1, F2 in East of England, and I did my core training years in Northwest London. So I've had a bit of a broad scope of experience of my trainers and fellow colleagues. Obviously, with the massive news now being the ongoing junior doctor strikes, we've had more than 2 weeks worth of days off work with a varying degree of partial walkouts where there is some senior cover and what's referred to as a full walkout where even consultants are not supposed to be on the shop floor. Obviously, the design of these strikes is to cause maximum disruption for lessons to be learned and hopefully for some change to be enacted. Ultimately, the whole point is a big statement from the junior doctor cohort to basically say that we are not satisfied with how we're being remunerated for the increasing pressures, as has been discussed at length during this session. There's a lot of workload on the shoulders of all healthcare providers, which is only increasing over time. And in real terms, our pay has fallen. Obviously, with the cost of living crisis fully underway and the cost of everything increasing and not looking to settle anytime soon, it only makes sense that we are also covered, at least in part, to make sure that our pay reflects the cost of living, and so that we're not left in a position where 10, 20 years down the line, people like myself are still unable to afford simple things like, places to live, vehicles to travel in, and other luxuries eventually.
Yeah, what I was asking was that I understand that there was an offer made by government. Why did you not accept? Because you say that there is cost of living is gone up and it's really a crisis situation for junior doctors to cope in the current environment. But when government made a deal, why did you not accept it?
I mean, put simply, we're represented by the BMA, and the BMA holds those meetings in our absence, representing all members of the BMA and at large the entire workforce. The offer that was put on the table was simply unsatisfactory and represented a real-time pay increase of approximately 8%, with, I think, a small bonus paid up front. It was not enough to cover what's being requested at this point, and really wouldn't make any significant dent in the current cost of living issue that we're having. It equates to essentially a couple of £100 extra per month, which I'm not saying is insignificant, but is certainly not at a satisfactory level. So at this point in time, it is a to and fro. One meeting is followed by another meeting where the BMA submit a request, and obviously the government give a counter request, and then at the end, where we're at, I think as of the past 2 meetings, there hasn't been any further movement past this 8% that we've been told about.
So how do you justify it to the public who are suffering because their operations have been cancelled, they have to wait long time? How do you justify? Because public doesn't, I mean, they may have a soft corner for you, but it doesn't help them when some of them may be fearing about any serious pathology in the form of cancer. Even though we know that cancer waiting times are different from general health illnesses. But how do you justify? What do you say to the public? Can you justify your acts?
I mean, firstly, I don't think there's any doctor that's proud of what's going on right now. I think we're all very empathetic with the public. But ultimately, as I mentioned, that this is a very, very targeted attempt. Exactly what is being shown and what is being actioned is within the law. We are allowed to strike, and especially when we're in such a dire financial situation that I have colleagues that are simply not able to afford life, just a basic standard of living without extra shifts, without overtime, without sometimes resorting to other work at other trusts. So firstly, we're not happy about it. It's not something that we're at all proud of. But simply put, we're in a situation where if this is allowed to continue, one, there's not going to be enough doctors on the shop floor because enough of us will have given up, basically accepted that the situation is not going to change and there's no hope for this current healthcare system in its current form. They will have left to go either to another country to practice, or they will have given up on medicine entirely and gone into finance or another industry, or waiting lists will have increased to such an unreasonable degree that people waiting for elective procedures simply will not have the patience to see it through, and they will eventually go private, which, controversial viewpoint, but one shared by myself and a few of my colleagues, perhaps this is the intention ultimately of the government, to send us down the way of privatization of the NHS.
So you mentioned some of your colleagues, they have considered immigrating to other countries. What about yourself? Do you think you would also take the same course?
Well,
personal question, but
having been trained within this system and having spent the past 7 years working within various trusts across, London and outside London as well, I've got a good relationship working within the NHS. I've had excellent mentors. I've had really, really wonderful exemplary training. Personally, I haven't got a huge amount of reason to leave the NHS because for me, my goodwill outshines, I guess, the issues that I'm having and the grievances that I have with pay. I'm personally in a position where I do undertake additional work within the trust that I work. I'm happy to do weekend operating lists with my consultants. And I feel that's sort of helpful on two fronts, because that allows me to basically pay the bills and live the life that I want to live. And it allows me to afford that. But it also allows me to give back to the long list of waiting patients, because these are elective operating lists that have been scheduled by the trust and have been allowed to go ahead basically to combat the waiting list that you've been talking about.
Yeah. And do you see any resolution in the near future?
I'm optimistic, but I can only speak on the experience that we've had up to this point, given the lack of action and really the lack of transparency from the government thus far. I can't see an end anytime soon. If we've been allowed to carry out this number of strikes with this enormous expensive, in terms of cost and time to patients, number of strikes, and the government hasn't seen this as a sort of crisis point, then what's to say that another 5 rounds of strikes won't achieve the same lack of initiative? So I'd like to think that there is some resolution on the horizon, but I'm a member of a number of WhatsApp groups where these things are being discussed, and the word from the inside is, watch this space, let's see what happens, but there's certainly nothing concrete.
I think they've got a point. They are struggling to cope with the increasing cost of life, and it's short-sightedness of government not to agree to some extent to what they're demanding, and their demands are not unfair. And I just hope that public does understand the pressures the junior doctors are going through at the moment. So from the point of view of resources, do you think NHS has got enough resources to cope with cutting down these waiting lists by doing initiative lists on the weekends and so on and so forth? So because we see that is happening a lot, and I think there is some political motive behind, because elections are not far and they have to prove that things were not too bad in NHS.
Yeah, I think that's why it come back to our initial discussion when we started, that it's a political football, and every party which is in power or which is in opposition use it as a political game, and I think we need to get out of it. You remember, if you go back, Bank of England used to be in the same state. We used to have interest rate rise up and down, and they used to go down before elections and then go up again after elections. Same thing is happening with this one. I think the governments need to look at not just 5 years, they need to look at long term. And I think that's where when I say again and again that NHS should be taken out of the political arena, and there should be a cross-party consensus. There should be a panel who should actually look after the budget, because I understand, because the biggest argument used against this notion of taking it out of the political arena is that it's a huge amount of taxpayers' money. Yes, there's a way around it. That panel should look after it, but it should be cross-party, so no individual party could be blamed. And then what we should do is that the professionals, both healthcare workers and the managers, need to sit together to devise the way forward. When I mentioned earlier about that Tony Blair's time, the most money went into NHS. But what it was spent on? It was spent on waiting list initiatives, right? And people, rather than actually putting into infrastructure. We did not increase the infrastructure. We did not increase the workforce. Most of the hospitals which were built, the new hospitals were all PFI. Staggering cost. PFI cost is a staggering cost. Most of the hospitals which are PFI, they have been in a deficit budget. And the reason is because they're paying a huge mortgage. Those companies, which are private companies, they have been given a fantastic contracts. The percentage of interest they're getting is huge. What happened? If that money had actually gone into infrastructure, increase the infrastructure, increase the workforce, today we would not be having this problem. I think this short-sightedness by just bringing the waiting list, that's why I said in the beginning, we shouldn't just talk about numbers. We should talk about what the patient's requirements are and how, as an NHS, we are fulfilling it.
But Mr. Khan, like during the times when junior doctor strikes resulted in cancellation of theatres and clinics and so on and so forth, we hear a lot of money was spent on we lost a lot of money. So do you not think that government could have actually considered paying the junior doctors instead of paying towards the losses?
I think that is a simplistic view for all of us to do that. And I think very logically, if you look at that, even anyone, all of us can understand it. So we are all surprised why this is not being done. I think I can understand from the other side, one of the problem is that they know that if once they accept the demand of healthcare workers, next will be the other the civil servants, and it will be a chain of reaction. And I think we know it, that present government is coming to an end of its term, so they don't want to look anything further. They are going to leave all these problems for the next government, who is going to struggle with them, and will have the same cycle of.
But they could consider increasing the MPs' pays. So, is there a separate agenda that they just don't think that NHS staff is worth considering for when it comes to issues like that?
I think there's always this worry because if you look around, NHS was formed by Labour Party, and this was their biggest achievement which they've done, and somehow it doesn't sit with the ideology of people in power. And NHS has been eroded gradually over the years. And the biggest reason why NHS has been eroded is that there is no investment in the infrastructure, and we've actually let things go backwards. And there's no forward planning. And I still, to be honest with you, I'd beg it and I'd request the government to look at it very seriously, that we should actually take it out of political arena.
Yeah. And is there any direction of how to cope with this current situation from government, or is individual trusts, they are actually making their own plans?
I think there is a lot of pressure on trust managements to bring the waiting list down, because elections are very near and they need those numbers. But their hands are tied because there's a limited workforce they've got to play with, and resources are limited. So
let's take online Mr. Sohail Said, another consultant surgeon. So thank you very much, Mr. Said, for joining us. Would you tell us what your trust is doing in order to reduce the waiting times for the patients?
Hi, Amara. Thanks very much for having me on your show. Well, I mean, I've been listening to all the conversations going on so far, and Mr. Khan has been pretty much spot on highlighting where the shortcomings are, and the junior doctor's perspective as well. And basically, it's always the political prerogative not to submit to strikes and to submit and give people what they want. But I mean, they need to think humanely. I mean, what kind of heartless people can do things like this and not allow? The last time the doctors, junior doctors, pay reforms were done were like 15 years ago. times have moved on, things have become more expensive, and nobody has ever paid any attention to all these struggles that they are going through. I mean, the interest rates are sky high right now. The cost of living, cost price of everything, even smallest accommodation, everything has gone up so much. Energy bills are very high. How are they even expected to survive on these? But that's another thing. You haven't asked me this question, but I thought I would just add on a little bit. And likewise, again, the the waiting lists have grown, and COVID had a big part to play on it. But we cannot keep banging on that old drum all the time. We need to move on. But then, how do you move on? Because there's not been a lot of investment done. We have been seeing in the last few years, even in the time of the last two governments that have changed, they have been chopping corners just till before the COVID. COVID turned the tables completely, and now we are in a situation where we have quadrupled the amount of work that we need to do to meet with the amount of demand that is coming through.
So
That
how
now
is your
into
trust
place.
coping? What is the strategy then? What is the solution in your trust?
Well, the solution is that they are offering extra initiative lists. We are doing extra clinics on weekends. We are doing extra initiative operating lists.
So do you have
because the
enough
waiting time-
resources to actually support those? Because of course the staff are paid extra to do those initiative lists. So do you have enough resources? Because we keep on
Yes,
hearing
the
that
trust
NHS
that-
doesn't have enough money to support the demands and all that. So where is that money coming from?
I can talk about my trust that basically during the last 2 years, we have had 2 new consultant appointments, which is obviously uh, helping to cope with the amount of work that was already present. In addition to this, the trust is looking at outsourcing. That's another thing which is now quite fashionable. Outsource whatever you have to other private companies that will try and sort it out. In
But
terms of
that
finances, where's
outsourcing,
the
is
money
it
coming
not
from?
more expensive than paying your own staff to do the work?
It's cheaper to pay the own staff to get the same amount of work done if they were given the right incentives. It's more expensive to outsource it to other people who will draw benefit from it and from your pocket.
So it's just the political glory that waiting lists have gone down, and no matter at what cost, and where junior doctors are actually trying to have their pays increased. They're paying money to senior consultant to do extra work on the weekends just to bring the waiting times down. So I don't know how can that be justified to public, but end of the day, the public wants to be treated because it's not their problem where the money is coming from. So do you think that that way you are seeing that the public is more satisfied with all this extra work or extra steps that have been taken by individual trusts?
I mean, the public have no other choice. The people who can afford to have private insurances, they buy the private insurances, get this work sorted. Some of the times when I'm sitting in a clinic, I'm looking at a referral that was done 1 year ago, and this patient had a simple problem that he's gone privately and had it sorted. So he does not even turn up on that clinic. So it's a waste of resource at one end, and at the other end, there's an extra expenditure on the poor patient's part. Public is not particularly happy, but this is do they have a choice? That's at the end of the day, it all precipitates down to what choices do you have.
Thank you very much, Mr. Said, for joining us. The issue remains the same, that it's a political matter, the waiting lists, initiatives, privatization. What is the solution? Can we see that in the near future we'll have some solution to satisfy our public, Mr. Khan?
It's very interesting, Amara. Before we just answer your question, can I just clarify one thing? When we talk about waiting list initiative, it isn't the work which the doctors are being paid extra for what they are employed. This is over and above their jobs. So people are, instead of spending time with their family and or doing other activities with their family, what they're doing is they're coming and doing an extra work. And that's what they're paid for. It ought to be made very clear. It isn't a gift to someone.
Yes, good to know.
It is what they earn from it.
Yeah.
So I think that's important for people to understand. I think it is unfortunate because the way the system is going, I can't see a clear-cut solution in the near future. I still believe on a principle of free at the point of delivery, because the best thing this country had was the National Health Service. And this was a beacon for this country, which was everyone else used to envy it. People used to look at it, okay, that's something can be done or not. This country did very well for that.
Yeah, the world acknowledged during
yes.
COVID times how NHS coped with the pressures was amazing.
Yeah. And it was a beacon. People used to look at it and people used to envy it. But what we've done is we've not kept ourselves in pace with it. The modern medicine has moved a long way. People are living longer. Technology is more expensive. We need to pay for all that. We need to factor all that when we're developing budgets for it. And I think that's where we are failing. And that will only happen when the professionals are involved in devising the service and running the service. And I think the earlier we get there, the better it is. We need to, I'm extremely sympathetic to junior doctors, right, for what they're struggling for. But instead of listening to them and sitting with them, negotiating with them, we are not. And I'll tell you one thing, although these doctors are on strike, but when there are emergencies there, they straight away come back and do it. Because that is what they are committed to in their lives. We should not forget that. We should not forget how much extra work the medics and the nurses do when they are working. Nurses are working flat out on their feet all the time in the wards, those 8 hours, 10 hours, 12-hour shifts. But we need to value all that.
Absolutely.
And we need to value these people and make sure that our system caters for them.
Yeah, thank you. One last and a very important question. Where do you see the role of physician associates? Because there is a lot of controversy going on and we respect all the healthcare professionals. But do you think they are a replacement of doctors?
No, they're not. I would ask the questions from those who think they are. Close the medical schools. Why do you think it needs 5 years to train a doctor? Why don't you just train them like them?
Because maybe NHS will run by...
It's a cheaper way of replacing that. And I think that's not right. To be fair with my physician associate colleagues, they are worthwhile, yes, but they need to work with the doctors, right? And there is no... Because there's a lot of... people need to understand there's a lot of training goes in to make a doctor today. And the reason that training is accepted is because all those who devise academicians who devise these trainings, they know what's required to train a medic because they're looking after your and my health. And I think we should not undervalue that.
Thank you very much, Mr. Khan, for your invaluable views and sharing your experience of working within NHS.